A 14-year-old boy visited my practice, escorted by his parents, with this orthodontic problem. He had a class 1 malocclusion, severe crowding on both dental arches, frontal crossbite, and a pronounced midline deviation of approximately 5 millimeters. His occlusion on the right side shows clearly that there was no space at all for the upper right canine. And this was his occlusion on the left side. There was no space for the upper left lateral incisor either, which was palatally blocked and in crossbite. This was the occlusal view of the upper dental arch. He also had severe dental crowding in the lower arch. This orthodontic problem caused an observable skeletal asymmetry. Notice that his lower jaw, the mandible, deviates to his left. This was not only a dental problem, but a skeletal problem too, affecting the development of both jaws and the face. The orthodontic problem was nicely corrected. It was a non-extraction orthodontic treatment. Here are the before and after photographs. For those who are interested, a brief review of this patient's orthodontic treatment follows. In the last part of this video, I will submit some of my own thoughts and comments. Treatment started with a Carriere motion appliance in order to distalize the upper buccal segments and create space to correct the crowding on the upper dental arch. After about 6 months, the Carriere was removed and fixed appliance was placed on the upper arch. The patient was instructed to keep on using class 2 elastics and the lower Essex retainer during sleep time. Approximately 8 months later, fixed appliance was placed on the lower arch as well. Notice that unilateral class 2 elastics were used on the right side in order to match the midlines as much as possible. The space required to resolve the lower anterior crowding was obtained by a slight buccal dentoalveolar expansion, interproximal reduction, and, unavoidably, proclination of the lower incisors. Correcting orthodontic problems with severe dental crowding without extracting any teeth at all most of the times results to a variable degree of upper and lower incisor proclination, as shown in these before-after photos here. This incisor proclination may, up to a point, be reduced by posterior tooth distalization, dentoalveolar expansion, and interproximal reduction, also known as stripping, but there are biological limits to how much distalization, expansion, and interproximal reduction should or can be performed and obtained. On the other hand, some incisor proclination can not only be tolerated, but may even be desired, because incisor proclination usually results in fuller lips, improving thus an initially flat profile as seen on these photos. Many orthodontists may choose to treat severe cases like this one by extracting 4 permanent teeth, usually premolars, and that could also be a perfectly reasonable and applicable treatment choice. But in my 38 plus years of clinical orthodontic experience, I can testify that the vast majority of patients resent the idea of permanent tooth extractions, and their parents feel exactly the same about it. I totally sympathize, and as a rule, I choose to avoid extractions, though, truth be told, there are cases in which extractions are impossible to avoid.